Thank you very much for that kind introduction. By training, I am a medical oncologist. I trained in Edinburgh, and then when I became a consultant, I moved from Edinburgh in Scotland to Cambridge in England to set up the Cancer Genetics Service within the National Health Service, so the public sector in England. And I know Vanessa said to me that she's not a clinician, so I hope that I will be able to explain cancer genetic testing in a way that everyone can understand it. Now, it's interesting that about 18 years ago, I was very involved with the European Society of Medical Oncology, ASCO-SMeO. And in fact, I was the first chair of the Cancer Genetics Expert Advisory Group at that time. They had just set up a cancer genetics group. And of course, we had a lot of interaction with ASCO at that time. That, of course, was many years ago. But I'm delighted to be here for this very innovative sounding collaboration between ASCO and your society. How do I put it on? Just ask you. Next one. So my title is rather provocative. Genetic testing can save lives in the breast cancer clinic. Can you hear me okay? Yeah. So I want to start by just going into traditional genetic testing practice in the clinic in relatively simple terms. Then talk about the concept of introducing wider genetic testing and give you some information on my clinical practice in London some time ago, when at that time we had both BRCA1 and 2 testing and panel testing, when we just introduced panel testing. So we were able to compare BRCA1 and 2 testing and pickup with panel testing and pickup. And then go on briefly to talk about widening testing to other young cancer patients and talk about the concept that increasing genetic testing in the clinic can save lives. So this diagram just illustrates the traditional method of genetic testing. These are patients with breast ovarian cancer. These are their female relatives, all of whom have a slight increased risk of developing breast cancer themselves. Within that group, there's a very small group that have a very strong risk of developing breast and ovarian cancer themselves because they have a very strong family history. And traditionally, we only offered testing to that small group. So you had to have a very strong family history initially before you were offered testing. So this is a good example of the sort of patient we used to see. This lady comes along, strong family history of breast cancer, and her aunt had ovarian cancer. What are the important messages to get over to this well lady? Well, the first message is, if there is a faulty gene there, her mum has one good copy and one faulty copy, and her mum passes one copy to her. So there's a 50% chance, even if there's a faulty gene in the family, that this well lady inherits a good copy of the gene. And that's a really, really important clinical statement, because many people think, my family history is so strong, I'm sure I'm going to develop breast cancer. 50% chance she inherits a good copy. In simple terms, looking at gene structure made up of CG, A, and T, in the BRCA1 gene, there's 100,000 of these letters arranged in a sequence, and a fault is caused by a change of a single letter. So it's a subtle spelling mistake, and it's anywhere along the lineup, which means that essentially genetic testing is a two-step process, traditionally. First step, we had to try and identify the fault in the family, and we did that by taking a blood sample from someone in the family with breast or ovarian cancer, work our way along the whole sequence of their genes till we found a fault in them, if we could. And if we could find the fault in the mum, say with breast cancer, we could then offer testing to her daughter in which we just looked at the single fault. And that's called single site testing. Once you know the fault in the family, you just look for that specific fault in the daughter. It's important to appreciate that when you do this business of working your way along the entire sequence, there's 3 possible results you get from the lab. 1, the sequence of all genes, normal. Or they found a fault in one of the genes which we know causes cancer of various descriptions. Occasionally, they find a change in the letters that they're not sure what it means. And they report that as an inconclusive result, a variant of unknown significance. And that is a real pain. It increases anxiety in the patient and the doctor because they've found something, but we're not sure what it means. And I think it's very important to warn everyone that's thinking of genetic testing, as in the whole sequencing, that they may get an inconclusive result. So up until recently, many of the families that I showed you, strong family history, would offer BRCA1 and 2 testing, it would come all back normal. And that was the clinical fact that drove the development of panel testing. So now there are a variety of panels. I'm going to just tell you about one, a myriad panel that they call MyRisk. And MyRisk has gone through various stages. This is a slightly older slide. There's 25 genes in this panel. There's now 28 genes in the panel. Doesn't matter how many genes. The concept is clear. That they look at genes involved in 8 different cancers, which are listed along the top here. And look at 25 genes listed down the side on a single blood sample. So every patient gets exactly the same test, looking at the sequence of all 25 genes covering the 8 common cancers. So now let me tell you a little bit about our experience in London. And this was at a time when the panel testing had come into the UK from Myriad in the States relatively early. So it was late 2013 for the next few years. And at that time, some of the insurance companies in the UK would not cover panel testing. They would only cover BRCA testing. So the result of that was that some patients only got BRCA and some patients got the full panel. Wasn't randomized, it was all to do with what the insurance company essentially would allow them to have. But the result was that we had a mixed cohort of those who had BRCA1 and 2 and those who had the full panel. And that's the information I'm showing you now. So in the overall cohort, 2 clinics, 400 tests done, 8 tests done. This just lists the different testing, BRCA sequencing, comprehensive BRCA and MyRisk. The 2 bottom lines are important. Comprehensive BRCA, 95 sequencing, full sequencing done, 9 mutations picked up. MyRisk, total panel, 247 samples done, whole sequencing, 42 mutations picked up. Next slide. So the MyRisk genes that were identified are listed here. BRCA1 and 2 and a whole list of others. The concept being that if you do the complete panel test, you double the number of pathogenic mutations you find when compared to BRCA1 and 2 alone. As we see here, 95 comprehensive BRCA, 9 mutations. MyRisk 247, 42 mutations. Roughly the same BRCA mutation rate in MyRisk and BRCA alone. And then there are other results about normal. And I wanted to concentrate just for a minute or two on this whole concept of people with a relatively weak family history who have a normal genetic test result. So in the overall cohort we looked at, you can see the figures here. Those with cancer, with strong family history or a weak family history. A strong family history implies that they will have an intervention on the basis of the family history, even with a normal genetic test. Conversely, a weak family history suggests they will not have an intervention, even having a normal genetic test. So that's why we were looking at those with a weak family history who had a normal test. And it's listed here. So 78% of tested patients had cancer, but the total that did not have cancer, 53, and most unaffected patients chose the panel test. 72 patients had cancer, a weak family history, and no abnormality, no pathogenic abnormality. So for these patients, further clinical intervention was avoided. And that to me is a really important concept. In the context of a strong family history, we would tend to act on the family history, not a normal genetic test. But in patients with a weak family history, if they have a normal genetic test, we would think no further intervention is required. Is that reasonably clear? Yep. Okay. Next one. So let me just go back. BRCA mutation carriers have, as you know, increased lifetime risk of breast cancer at a young age and ovarian cancer, lifetime risk up to 40%. Next one. So this just shows you the effectiveness of intervention. And what we're looking at here is the effectiveness of prophylactic oophorectomy on ovarian cancer risk in a BRCA1 or 2 carrier. It's up to 96% effective. It's not 100% effective, but it's highly effective. A few people have a prophylactic oophorectomy and still develop ovarian cancer, but the vast majority don't. Now consider this lady, young woman, triple negative breast cancer, age 33. No family history at all. She's got 2 young children. If we offer a myriad panel test to that lady, the clinical consequences are very important. If that lady has a mutation, say in BRCA1, this is a young lady with early breast cancer, no family history. If she has a mutation in BRCA1, her risk of developing ovarian cancer within the 20 years of her breast cancer diagnosis is up to 35%. Up to 35% in the 20 years after her breast cancer diagnosis. If we offer her a panel test and it comes back normal, remember this is a lady with no family history, her risk of developing ovarian cancer is the same as the normal population. So for this lady, a mutation has an important clinical effect on her treatment because she should think about prophylactic oophorectomy, which will probably save her life from ovarian cancer. If she doesn't have a mutation in the panel test, her risk of developing ovarian cancer is the same as everyone else, and she doesn't need a further intervention. So what we have here is an opportunity to identify women at high risk of inherited ovarian cancer. And as I've already showed you, we now have an effective intervention for those ladies. Screening in high-risk ladies for ovarian cancer doesn't work. Removing the ovaries in high-risk ladies works very effectively, although it's not 100%. And that is one of the reasons I am so keen that we should start to think about offering genetic testing to young patients with cancer, even if they have no family history, because it can be very important for their individual clinical care. Thank you. So, in summary, we've gone over the traditional inherited practice in genetics, traditional, picking out high-risk families, offering them testing. We've talked about the implications of introducing panel testing routinely rather than just BRCA1 or 2, and how that doubles the pickup of pathogenic mutations by using a panel test. We've talked a little bit about extending the patient pool to which we offer testing, so forgetting really about strong family history and offer testing to all young patients, even if they have no family history. The concept being driving these two initiatives are that increased genetic testing can save lives in the cancer clinic. Thank you very much for your attention.